Hyperaldosteronism is a medical condition, endocrinal disorders. Look at this kidneys, top of the kidney adrenal gland producing aldosterone. CT findings. Look at this abnormalities in adrenal gland. Then MRI findings. Look at this. Detail going on. Introduction. Hyperaldosteronism is a medical condition characterized by excessive production of aldosterone, a hormone secreted by the adrenal glands. This hormone plays a vital role in regulating blood pressure and maintaining electrolyte balance by promoting sodium retention and potassium extraction by the kidneys. When aldosterone levels are abnormally high, it can lead to hypertension and electrolyte imbalances, potentially causing serious health issues. Etymology. The term hyperaldosteronism is derived from the prefix hyper, meaning excessive, and aldosterone, the name of the hormone produced by adrenal glands that regulates sodium and potassium balance. The suffix ism indicates a condition making hyperaldosteronism the state of excessive aldosterone production. Definition. Hyperaldosteronism is defined as a disorder where there is excessive production of aldosterone either due to primary or secondary causes leading to sodium retention, potassium extraction, and result clinical manifestations such as hypertension and hypocalcemia. Type 1. Primary hyperaldosteronism, Cone syndrome, caused by autonomous overproduction of aldosterone, often due to adrenal adenoma or bilateral adrenal hyperplasia. To secondary hyperaldosteronism due to excessive stimulation of aldosterone production, usually in response to conditions such as renal artery stenosis, heart failure, or cirrhosis. 3. Glucocorticoid remediable aldosteronism GRA, a rare genetic condition where aldosterone production is regulated by ACTH. Causes primary hyperaldosteronism 1. Adrenal adenoma, Cone syndrome 2. Bilateral adrenal hyperplasia 3. Adrenal carcinoma is rare one. Secondary hyperaldosteronism 1. Renal artery stenosis 2. Chronic kidney disease 3. Heart failure 4. Cirrhosis with ascites 5. Nephrotic syndrome. Risk factors 1. Family history of hypertension or adrenal disorder 2. Chronic kidney disease 3. Obesity 4. Age commonly diagnosed between 30 and 50 years 5. Female sex slightly more prevalent. Complications 1. Severe hypertension 2. Cardiovascular complications stroke myocardial infarction 3. Hypokalemia related to complications muscle weakness arrhythmias 4. Chronic kidney disease 5. Osteoporosis due to chronic metabolic alkalosis. Pathophysiology excessive aldosterone increases sodium reabsorption in the renal tubules leading to water retention and expansion of extracellular fluid volume. Concurrently, potassium and hydrogen ions are excreted, causing hypokalemia and metabolic alkalosis. The expanded plasma volume, elevated blood pressure, and chronic high aldosterone levels may contribute to vascular remodeling and fibrosis, further exacerbating cardiovascular risk. Here is step-by-step breakdown of its pathophysiology. 1. Stimulus for increased aldosterone production. Primary hyperaldosteronism, Cone syndrome. Secondary hyperaldosteronism. 2. Effects on renal tubules. 3. Sodium retention and potassium loss. Sodium retention and potassium loss. 4. Suppression of renin angiotensin system. 5. Hypertension and its consequences. 6. Metabolic alkalosis. 7. Differentiation between primary and secondary hyperaldosteronism. Primary hyperaldosteronism, high aldosterone levels, low renin activity. Secondary hyperaldosteronism, both aldosterone and renin levels are elevated. Clinical features and confirmation systems include hypertension, hypokalemia, muscle cramps, fatigue. Diagnosis elevated aldosterone to renin rate and ratio ARR in blood test. Imaging studies example CT or MRI for adrenal abnormalities, adrenal vein sampling for localization of aldosterone secretion. Signs and symptoms 1. Hypertension, often resistant to standard treatments. 2. Hypokalemia, muscle weakness, fatigue, cramps, palpitations, polyuria, and polydipsia. 3. Other symptoms headache, numbness or tingling, increased thirst. Diagnosis 1. Laboratory test elevated aldosterone to renin rate ARR, serum electrolytes, hypokalemia, metabolic alkalosis. 2. Imaging studies CT or MRI of adrenal glands. 3. Confirmatory tests saline infusion test, captopril challenge test. 4. Adrenal venous sampling to differentiate between unilateral and bilateral adrenal involvement. A nursing diagnosis 1. Imbalanced nutrition less than body requirements related to electrolyte imbalance. 2. Risk for decreased cardiac output related to hypokalemia and hypertension. 3. Risk for fluid volume overload related to sodium retention. 4. Anxiety related to diagnosis and treatment process. 5. Knowledge deficit related to disease process and management. Disease management. First, medical management. 1. Pharmacological therapy. Mineralocorticoids receptor antagonist. Example spironolactone and epinephrine. Potassium supplements if hypocalcemia is severe. To surgical treatment. Adrenalectomy is in case of unilateral adrenal adenoma. 3. Treatment of secondary causes addressing underlying conditions, example renal artery stenosis. Nursing management 1. Monitor blood pressure and serum electrolyte levels regularly. To educate patients about dietary modifications, low sodium, adequate potassium. 3. Encourage adherence to medications. 4. Provide emotional support and education about the disease process. Treatment options. 1. Pharmacological treatment. Spironolactone or eplerenone to block adenostironin effects. Antihypertensive drugs for blood pressure control. To surgical treatment, unilateral adrenalectomy for adenomas. 3. Lifestyle modifications, low sodium diet, regular exercise. Psychosocial medicine. 1. Emotional stress due to chronic illness. 2. Impact of hypertension on quality of life. 3. Financial burden of long-term medical treatment. 4. Family dynamics and support system. 5. Anxiety or depression related to complications. So they need following psychosocial therapies. First therapy, cognitive behavioral therapy, CBT. 2. Support groups. 3. Family therapy and support. 4. Psychoeducation. 5. Mindfulness based stress reduction. Prevention. 1. Regular screening for individuals with a family history of hyperaldosteronism or resistant hypertension. 2. Early detection and management of risk factors like obesity and kidney disease. 3. Routine blood pressure monitoring and electrolyte evaluation. In conclusion, hyperaldosteronism is a potentially reversible cause of hypertension and hypokalemia if diagnosed and treated promptly. Awareness of the signs and symptoms, along with appropriate diagnostic and management strategies, can prevent complications and improve patient outcomes. Collaborative care is essential for effective management and support for affected individuals. Thank you. Have a nice day.